Welcome to the Moss Report with your host, Dr. Ralph W. Moss.
Hi, this is Ralph Moss and with the Moss Report. Today we have a very, very special guest. I'm really honored and extremely happy to have and to um, introduce to our audience Rasha Simmons, MD, MS, MBA, who is a professor of surgery and a breast surgeon at the famous Weill Cornell Medicine in New York City. If those of you who are not familiar, this is, I think, part of the number one hospital system in New York. It's a fantastic place which brings together the Weill Medical School of Cornell and Presbyterian and many famous and historic organizations. So that's part of it. She's also a director of the Office of Women at Weill Cornell, associate dean of diversity and inclusion, and many, many other titles. So welcome to our podcast, Dr. Simmons.
Thank you, Dr. Moss. It's a pleasure to be here.
Thank you. And thanks for agreeing to appear. I know how busy you are and how valuable your time is. I want to start out by, if I can, with making a few sort of philosophical remarks about this field. We're going to be talking about a few things. One of them is your innovative way of performing mastectomies and operations for breast cancer, which I think is fantastic. And with people, we have more interest in breast cancer than I would say, almost all the other cancers combined. So it's going to be a fantastic interest to the listeners to our podcast. But also, you've made a really historic move in terms of your sponsoring and carrying out trials with cryoablation, which is the use of cold probes for the treatment of cancer. This is a top. I mean, these two things go together. The question of less mutilating forms of breast cancer treatment and the use of a simple probe with ultra cold temperatures to destroy a tumor, which, as I understand from your writings and also from prior knowledge, I mean, is such a big step forward for vis-a-vis what we knew not so long ago. And this, I want to mention that I had a background. I was a science writer and official at Memorial Sloan Kettering, across the street from Cornell, Weill, back in the 70s. And at that time, the opposition to even doing a lumpectomy was so fierce that the heads of the breast service at Memorial tried in about 76 or 77, tried to get me to write an article, ghostwrite an article for them, I guess, on condemning lumpectomy as a form of quackery, basically. They were still fighting it to that degree in the mid to late 70s. And I refused to do that, which was, at some risk to myself, to my job at that point. But of course, I could see the way the wind was blowing, and I didn't want any part of that. But that's just within our lifetime, we've seen this shift from Halsted radical mastectomies as the standard to the kind of thing that, lumpectomies, but the kind of thing you're doing where you can do a mastectomy with very minimal cosmetic deficits at all, to the point where, as you remarked in one of your publications, that sometimes other doctors can't even tell they ask which breast had the mastectomy. So, I mean, that's about as perfect as it gets, I think. It must be enormously satisfying to you. If I may make one more remark, and that is that I have on my desktop a book, and the book I'm looking at it as we speak. Maybe even Rachel will figure out a way to to put this at our website. And it's called "On the Treatment of Cancer by Congelation and an Improved Mode of Pressure" by James Arnott, MD. Congelation was an old name for cryoablation, and the date of the book is 1855. And I leave it to the listeners to think about the significance of this. That there were even books being written more than 150 years ago about the use of cold compresses and cold solutions in the treatment of cancer. This was demonstrated at the famous Crystal Palace exhibition in London in the 1850s. So, I mean, I take my hat off to you, what you've done and how you've done this, how you've managed to get this accepted throughout the medical community. But it's something that has taken us more than a century to put across. So with that, I open this up and I'll say, again, welcome. And I want to hear about the struggle. I want to hear, first of all, what have you found vis-a-vis cryoablation? Because I know, and you have many scientific publications on this, but what was actually the discovery, and how did that come about?
Sure. So the cryoablation really falls under the general umbrella of what we call de-escalation in breast cancer treatment. And what we're finding is that there are ways that we can safely offer breast cancer patients less invasive treatments, maybe less radiation, less chemotherapy, less surgery. And as long as if we can select the patients appropriately and safely, then obviously it's a huge advantage for our patients. And cryoablation is one of those elements. And so cryoablation is something that we started looking at with fibroadenomas. Fibroadenomas are a benign little fleshy tumor that are very common in the breast, particularly in younger women. It's kind of like the fibroids that many women get in their uterus. It's a similar idea, but they get them in their breast. So they don't
Mhm.
turn into cancer, and they're not something we're terribly worried about. But sometimes they get big, sometimes they're uncomfortable, and patients may just wish to have them removed because they bother them for various reasons. So traditionally, it was always surgery to remove fibroadenomas. And then we started looking at the idea of possibly doing cryoablation on fibroadenomas. And we found that it worked really well. And so the process of cryoablation, just go over that a little bit, is an ultrasound guided procedure. It's an office procedure. It takes about 20 minutes to do. And one of the beauties of the cryoablation is the freezing process itself actually acts as an anesthetic. So once you numb the skin and make a tiny little incision and insert the probe and begin the freezing, you don't have to even give the patient any more local anesthesia or certainly not any kind of sedation. The patient's wide awake, talking to you, sitting there often fascinated while they're watching the procedure on the ultrasound monitor beside the bed. And so we use the ultrasound to guide that probe right into the middle of the tumor, be it fibroadenoma or be it cancer. And then we began the process of cooling the tip of that probe. The probe is about the size of a pencil. So it inserts very easily. It's a very sharp tip. We insert it very easily into the lesion we want to ablate, to destroy. And like I said, it takes about 20 minutes or so. We have found that it works best if you do a freeze and then a thaw, a second freeze and a thaw. It's more effective at destroying the tumor than a one freeze process. So we do this, and then we're very careful to watch the freeze ball, as we call it, kind of like an ice cube, a circular spherical ice cube that forms at the tip of this probe. And you can see on ultrasound when it actually engulfs the lesion. You can see how big it is. You can watch it actually incorporate the lesion. We have to be very careful when we're doing this, though, to not get a freeze burn on the skin. So the ultrasound in real time while we're doing the procedure tells us the distance from the skin to the top of the freeze ball. And if it starts getting close, then you can just inject a little bit of saline, room temperature saline, between the skin and the freeze ball, and it creates a separation to keep the skin safe from injury.
Mm-hmm.
So we monitor the size. We typically want the freeze ball to be about a half a centimeter on all the edges beyond what the lesion we want to destroy. So if we have a 1 centimeter fibroadenoma, then you're going to want a half a centimeter on each side, so about a 2 centimeter freeze ball. That would be typical. Same thing with the cancers that they'll talk about later. So we do the ablation. The probe then has a process of warming the tip that loosens it from the ice ball. You pull it out, you put a Band-Aid on, and the patient goes home. It's very, very straightforward. It's incredibly easy for the patient. Now, you have to explain to the patient that they're going to feel that freeze ball after you do this. They're going to be swollen, and they're going to probably be bruised, and that's all perfectly normal and expected. But they really have almost no discomfort. It's really amazing. The freezing does not cause any kind of discomfort for the patients. Maybe a Tylenol they would take. They don't even need a kind of narcotic at all, unlike a surgical procedure. So then we followed these patients. So we did a series of fibroadenomas. We followed the patients to see what happened to these fibroadenomas. And the vast majority of them just dissolved. They just went away. And we were also very curious to see what would happen on imaging. Now, most fibroadenomas occur in young women, so a lot of them were not getting mammograms. But for the ones who did get mammograms, we were particularly curious to see what does the mammogram look like after the cryoablation, thinking ahead as far as if we start doing this on cancers, what is it going to look like? Is it going to be confusing? Are we going to see a lot of scar tissue, a lot of distortion, a lot of calcifications that could be very confusing on future imaging? And that's not at all what we saw. They basically just went away. So that also led us to say that, number one, it works. It works at destroying tumors. And number two, there's not going to be a lot of artifact that's left that's going to be confusing in the follow-up of these patients. So we did these studies. Then we started talking about what if we applied this technology to cancer? Do we think it would work? We thought it probably would. We didn't know, but we thought it probably would. And so then we did a trial that was an NCI funded national trial, multiple centers. I was the lead investigator on this. And we took patients, and about 100 patients, and we ablated the cancers, and then we resected all of them. So that was our gold standard, that we did the ablation, but then we did a lumpectomy. And then with that pathology, we're really able to say, was the cancer destroyed or was it not destroyed?
Yeah.
Now, we were careful in our selection of these patients. We had learned a few things from the cryoablation study as far as size limitations, as far as location in the breast, that sort of thing. And of course, it had to be a cancer that was seen by ultrasound, because the ultrasound is what we're using to guide the probe. So if you can't see it on ultrasound, we wouldn't be able to localize the lesion for cryoablation. So it needed to be small. We said, let's do less than 2 centimeters, which would be what we call a T1 stage of a breast cancer, so early breast cancers. We also wanted to be careful in the fact that we didn't want highly aggressive breast cancers. We wanted to have a fairly homogeneous population. And then since we ablated them, we were also curious what the MRI would look like on these patients. And we wanted to, again, carefully select patients that didn't have a lot else going on in the breast by MRI. So all the patients got an MRI before the ablation. Did the ablation, then we waited a few weeks, and then we would do a second MRI. And the reason we did that was we were, again, thinking ahead, saying, if at some point we get to a trial, if this works, where we don't resect it, what are we going to be able to do to say we got the cancer and got the whole cancer? Maybe MRI would tell us. So if the MRI shows cancer clearly before ablation and doesn't show it after the ablation, could that be a surrogate for pathology to be able to say the cancer's dead? We're done. So
Hmm.
that was our hypothesis. So again, the patients had screening, they had to meet certain criteria, then it had to be visible on ultrasound, they had an MRI before the ablation, it had to be visible on MRI. Then we did the ablations, then we did a second MRI, then we took the patient to the operating room and we did the resection. Usually lumpectomy. A few of the patients had mastectomies, but most of them had lumpectomies. And then everything else involving their treatment was exactly the same as it would be if we had not done the cryoablation. So if they were a candidate for a sentinel lymph node biopsy, we did that. If they needed more nodes removed, the node dissection, we did that. If they would have had radiation, we did radiation. If they were going to have either a pill, like a hormone blocker pill, one of the aromatase inhibitors, or chemotherapy, we did that. All standard of care. But our endpoints were, number one, the MRI. Was it predictive? Number two, how did we see as far as the pathology? So what we found was the MRIs were pretty good, but they weren't as good as we were hoping they would be. So that was a little discouraging. That was not going to end up being a really good correlate. As far as the pathology was really impressive because where we ablated, the cancer was dead. It was completely
Hmm.
dead. Now, there were some variations in some patients that we did not find a complete death of the cancer, but we learned a lot from this study. And what we learned was that some cancers are not as visible, clearly visible on imaging as others. For example, the subtype of breast cancer called lobular. So with those, we couldn't see the target as clearly, and that led to a few patients that ended up having residual cancer on resection. We also, you can't really see what we call calcifications, microcalcifications on ultrasound. So we tried very carefully to make sure that we weren't including patients that had a lot of calcifications. And that also was a bit of an issue. Sometimes the cancers were a little bigger than we thought they would be on our preoperative imaging. So we ablated what we thought was the cancer, but there might have been a little edge that didn't get ablated because, again, our imaging wasn't good enough to tell us that for sure.
Hmm.
And then a lot of it was quite frankly the skill of who was placing the probe.
Hmm.
And not surprisingly, if the probe is placed right in the middle of your lesion and you can see the lesion clearly and you ablate it to where you think it should be, it worked really well. If the probe was placed off center or not really in the right place, well, then we didn't have a successful ablation. So we learned that the technique of the person doing the cryoablation, the ultrasound skills, is also critically important. Be it a surgeon or be it a radiologist, whichever it would be, it's really clearly important. But that makes sense that it would be that way. So I also participated in another trial that is still underway. We have accrued the patients, but now we're in follow up. And that trial was the next step. That trial was doing the ablation on highly selected patients and not resecting the cancers.
Hmm.
And now we're following them for the endpoints of local recurrence. And we're looking at a 5-year endpoint local recurrence. So the data is not mature enough to be able to say at 5 years that we have equal results of surgical biopsy. But we do have data at this point to say at about 2 years, it's looking really good as far as the same type of recurrence rates as we would see with the surgical lumpectomy.
Right. In your paper, which I'm looking at here, you're the senior author, just came out October 2021, and it says that find that the IBTR rate was basically 2%,
Exactly.
4 out of 194 patients. Could you explain what that means?
So what that means is the local recurrence rate was about 2% at that point, which is
Which is phenomenal,
which is what you would see with surgical resections, if not better. So that's
if
actually
not
very
better.
exciting. So I think this is something that will be in the armamentarium of how we treat breast cancer, more so potentially going forward. What I think are some areas that would be exciting to explore next. I mean, obviously, we want to get the mature data from this trial, but I would love to figure out a way to apply this technology to ductal carcinoma in situ, stage 0 breast
Hmm.
cancer. Now,
Right.
the challenge there, I mean, the good thing about that is we're seeing more and more DCIS, ductal carcinoma in situ, because we're getting better and better at finding breast cancer early, which is great.
Yeah. Yeah.
And often it's a tiny little spot of calcifications. So if we were able to figure out a way to put that probe in and target the calcifications, I think it'd be a home run. Now, the issue is that we can't see calcifications on ultrasound. So I'm working with a company right now, and we're trying to figure out how can we target those calcifications and use it as a ablation target for cryoablation. So I think it's maybe doable. I think it probably is doable. It's just about figuring out how to do it. So we're working on that right now. And the reason I
Hmm.
say they're the perfect patient is for calcifications or DCIS, those patients do not need to have any surgery in the axilla, in the lymph nodes, because stage
Hmm.
0 breast cancer doesn't go to the lymph nodes. So
Yeah.
that's why they're so perfect for cryoablation, because it's a little frustrating now if we have patients where we say, okay, we can do your cryoablation and avoid you a lumpectomy, but we have to take you to the operating room and take out a lymph node. Well, then that kind of defeats the whole purpose of avoiding going to the operating room.
Right.
So that's why I think DCIS would be a really ideal population. We just had to figure out the logistics of how to do cryoablation on these patients and calcifications.
Hmm.
Now having said that, I will also say that I think as we go forward, it is, I would say, inevitable, not even just likely, it's inevitable that we are going to be doing less and less surgery in the armpit for our patients that have invasive breast cancer, because we're going to be able to tell so much information from the little diagnostic core biopsy done by the radiologist, that we're going to be able to say accurately this patient is going to have clean lymph nodes. So then there's no reason to take out 2 or 3 lymph nodes to prove that they're clean, because we're going to know that from these molecular and genomic tests that we're going to be able to offer patients. So I think that population of patients where we don't have to go to the operating room to take out lymph nodes and therefore would be fantastic candidates for cryoablation is going to be broadening as we go forward.
Yeah, it's a fantastic prospect. Did you have any difficulty getting Institutional Review Board (IRB) approval for the trial?
That was a bit of a challenge, yes. I mean, it's a very, quite frankly, a very forward-thinking trial, and
Yeah.
it's very different than what people are used to thinking about as far as resecting cancers. I'll even tell you that I actually struggled quite a bit with getting approval from the NCI. I mean, that was one
Hmm.
of my biggest hurdles. And then when I finally explained to the review board, this really isn't any different than taking a patient and giving them chemotherapy before surgery, neoadjuvant chemotherapy, and being fortunate enough that those certain patients, their cancers melt away completely, and then you don't have
Hmm.
pathology at the end. It's really the
Yeah.
same thing. Because if you
Yeah.
do the cryoablation, you're not going to have pathology at the end. You're not going to have the markers. And so you have to get all of that on your core up front. But historically, people had a real satisfaction of having the tumor be removed and then looking at everything under the microscope and saying, we have this margin's close, this is the exact size. You don't have the luxury of that if you do cryoablation, but you don't necessarily need it if you're appropriate in your selection of your patients and you're careful and thoughtful in how you treat the patients.
Hmm. Hmm. Well, it definitely seems like a tremendous step forward, and it's. Do you find your colleagues, your surgical colleagues, are receptive to this? After all, unless they learn a new skill, a pretty important new skill, they're not going to really be able to participate in this. So, is there resistance to it, would you say?
Well, there might be, understandably, but I don't think it's
Yeah.
any different than other areas of medicine where certain surgical skills were eclipsed by skills by other physicians, often radiologists. I mean, think about cardiac and vascular surgery. And now we
Hmm.
have so many interventionalists that can put in stents, put in valves, for goodness sakes. I mean, there are just so many
Right.
things that can be done now that
Yes.
2 decades ago required a surgical intervention.
Yeah.
And so I think that this is going to be a similar theme, that it's going to quite often go into the hands of the radiologist, and that's okay. It needs to be done by, as I said earlier, whoever places the probe well and accurately.
Hmm.
And there, I think, certainly is an opportunity for radiologists to be taking over this, or partnering, let's say that, to be partnering in this
Hmm.
in this part of treatment for breast cancer.
Hmm. Or it could be breast, oncologists specializing in breast. I mean, where the other area where cryo is being used pretty well, it's being used is in prostate. And I had this done to myself 6 years ago. I had two large aggressive tumors in my prostate, Gleason 8 tumors, and they, Samir Taneja at NYU, ablated them, cryoablated them.
Mhm.
It wouldn't, so far so good for me, but no sign of any further problem there. So it's personal for me as well. I think it's fantastic technology, and I was very struck by the fact that he's not he is a surgeon, he's a urologist, but he made the transition to doing a lot of what he does is it's cryo, so it became another tool in the toolbox essentially for the people who already were treating the disease. And it's not a large number of people. I think you have a larger group uh, in your at least the terms of the co-authors on your latest paper is like a who's who, right? I mean, you got 20 different organizations involved in this. So from Georgetown or Bridgeport Hospital, I mean, it's all over the country.
Mhm.
New Mexico, Arizona, Pennsylvania. You've more or less covered the country, the U.S. with this. So I think it's pretty amazing what you've done. Do you see? Are you optimistic about this becoming a standard treatment?
Oh, I am. I absolutely am. I mean, it's a lot of it, though, right now is a challenge with reimbursement. So, as
Hmm.
usual, reimbursement lags behind new technology. So, to become truly mainstream, there's going to need to be reimbursement. On a clinical trial, that's not an issue. But outside of
Yeah.
clinical trial, it's going to be more limited unless we're able to establish reimbursement. And some of that also, often in breast cancer, is the voice of the advocacy groups. When the voice of the advocacy groups say this is what women want for breast cancer treatment, then often that's heard, and it can shift the needle a bit as far as an understanding of why it would be important to establish codes and reimbursement for these newer technologies.
The way you describe it in one of your articles or one of your interviews, I forget which it was, is basically, I mean, women are coming in. It's like a half hour procedure. There's no pain, or I mean, certainly significantly less pain involved, very little, if any, loss of blood, and basically put a band aid on it and they're done. How could, I mean, once the word of this gets out, of course there's going to be an uprising on the part of women who, I mean, not that breast surgery is so terrible, but it's still a very complicated thing with a greater possibility of infection, pain, bleeding, or fright, the fear factor. It's enormous. And when I tell people about cryoablation, they're amazed. I mean, that such a thing exists even. It just appeals to the mind. And I think it puts people's minds at ease because it seems more like going in to your dermatologist office and having an actinic keratosis removed than surgery. Going under the knife is a scary thing for anybody and a bit of a dangerous thing. So I would think that you must be getting a tremendous amount of women who are, excited about this and wanting to do this.
We do. I mean, the other advantage to appreciate is that by not going to the operating room, it's really quite cost effective. Going to the
Yeah.
operating room is an expensive ordeal.
Yeah.
You've got the room itself, you've got all the staff, you've got the anesthesiologist, you've got it's and then you have pathology, which you wouldn't have with this. So there's a lot of expense in going to the operating room. So I hope that just the acknowledgement of the enormous cost saving for a really common disease would be
Yeah.
something that could also be attractive to those who establish codes and would be interested in helping establish reimbursement for this technology.
Yes, it's a great point. The other thing I wanted to ask you about is the so-called abscopal effect or bystander effect that you've written about this too. Uh, for the listeners, what that means is that there's an added bonus to doing ablation and particularly cryo. It seems to be particularly for cryoablation, which is, to put it in simple terms, when you dissolve a tumor with cold, you're letting a little bit of the tumor antigens or the markers of the tumor into the bloodstream, and it functions as kind of a vaccine created within the person. I'm putting it all in simple terms, but I mean, that's been noted for a long time, because what the bystander effect is, it means if you destroy one tumor and the person has another tumor that you don't destroy with cryoablation, sometimes that second tumor goes away without you having done anything directly to it, right? And they call that abscopal or bystander effect. So I'm wondering if you could comment on that and how you feel, where you feel studies could be done in the future to explore that issue.
Right. So the theory of that came from some somewhat historical data on mice with breast cancer and cryoablation. And what was found was that if a mouse had breast cancer and had disease, metastatic disease, a disease in the rest of the body, in the bones and the liver, if they cryoablated the primary breast lesion, not only did the primary breast lesion melt away, but the metastatic disease melted away. I mean, that's incredibly exciting.
Yeah.
So that is partially why the women who went under the study where we did the lumpectomy after the cryoablation, they understood that. And they say, I'm willing to do this because I can't get cryoablation from my tumor otherwise. And there might actually be a survival advantage of having
Yeah.
cryoablation. I'm willing to have cryoablation followed by a lumpectomy. That's okay. So that was one of the ways we were able to recruit patients into that trial. Now,
Mhm.
I'll be very curious to see the longer term effects of this current trial where we're leaving the cancer in ablated. And then, of course, that'll be more overall survival. And that's going to be 5-year, 10-year data on our population of our study group. But we may see that. We may see the cryoablation patients actually have a better survival than those that would have traditionally had a surgical lumpectomy.
Mhm. And it's a way of getting a very powerful boost to the immune system without having to do anything special. It's just sort of an added bonus. Yeah. Well, thank you so much for this explanation. I also want to ask you about your surgical work because it's also very exciting. I'm amazed that, I mean, describe for us this procedure where you save the skin of the breast and the nipple of the breast. It sounds great. I just couldn't believe that this is an innovation. You would think that this is what would have been the standard 30 years ago or more. But tell us about that and how that came about. Were you the first one to do that?
Well, yeah, the areola sparing I was, and then but
Hmm.
it was a gradation. So what happened? Just to talk historically for a few minutes, we used to do these mastectomies. We took a lot of skin, and what we found was that we began taking less and less skin, and it didn't make any difference as far as local recurrence or on survival. So that was good. There was always a great deal of mystique about the nipple itself, that the nipple had to be removed because it would harbor this ductal tissue and would have a recurrence if it was left intact. So the first step that I did was this areola sparing mastectomy because I said, the areola, that's the skin around the nipple itself, that kind of pink
Hmm.
tan skin.
Hmm.
So, the areola is really just skin. So why is that any different than the other breast skin? So I
Hmm.
started doing areola sparing mastectomies and found that the recurrence rates were the same. They weren't any higher than taking the nipple and the areola. So the next step was actually saving the nipple. Now, when I do that, I explain to patients it's with the caveat that I always remove the breast tissue sort of right inside and behind the nipple itself. And I send that off for a separate pathologic analysis. And if that comes back as benign, then I am totally fine saving the nipple and the areola on these patients. If it comes back as cancer, then I do go back. Now, one could argue maybe you could do radiation or something else, maybe, but that's not where we are right now. So, with those patients, which are pretty few, honestly, I go
What
back.
about what percentage would you say that is?
Oh, I'd say less than 1%. I mean, it's low. It's really
Okay.
low
Right.
where
Right.
we find a positive nipple biopsy. And I mean, there's some patients, like I saw a patient just yesterday who clearly has nipple involvement of her cancer. Her cancer is right behind the nipple, it's growing into the
Hmm.
nipple. She's not someone that we're going to save the nipple. That wouldn't be appropriate. It wouldn't be safe.
Yeah. Yeah.
But that also, it's a real minority of patients.
Yeah.
So by being able to save all the skin, save the nipple and the areola, it's a huge bonus for these patients because the incisions that I make are down in the crease underneath the breast called the inframammary fold. Women have a natural wrinkle there anyway. And so when
Hmm.
they're reconstructed, they don't even see that incision. And then through that
Hmm.
incision, I remove all the breast tissue, I save all the skin, I save the nipple and the areola, and then the plastic surgeon will either put in an implant or bring up some fat from the abdomen called a tram or a DIEP and move that up and fill in the volume of the breast tissue that I've removed. And they look fantastic. I mean, they really look fantastic. I mean, patients often say, I look better than before I had my surgery. And
Hmm.
so it's really a wonderful bonus for these women who either have to have a mastectomy or may choose to have a mastectomy, but it's a wonderful option for them and it makes it an easier decision to be able to get this beautiful result after their surgery.
And what a difference. I mean, it also, the fact that the great majority of women in this, with this situation are going to be left fully like they'd never had the surgery, basically. I mean, only they would know, removes a lot of the fear factor. And fear, I believe, is what keeps a lot of people from going for treatment or going for regular mammograms because they associate having cancer and cancer surgery with disfigurement, and it's such a symbolically important part of the body. Um, and it's interesting that people who reject surgery and reject conventional therapy entirely. My experience, I have no proof of this, but they're almost always women with breast cancer. I think it's this fear of it, whereas what you're describing and what you're doing basically uh, makes it a very uh, much less emotionally fraught issue, and then it becomes a relatively minor thing, right? I mean, in terms of the how long does that procedure take, and how would you describe it in terms of the subjective effect?
Sure. So what I tell patients is the length of the surgery, the stay in the hospital, and the recovery time all depend upon the choice of reconstruction. because my surgery is exactly the same, whichever reconstruction type
Mhm.
they choose. So it's
Mhm.
going to be somewhere between 45 minutes to an hour per breast. So if we're doing both bilateral, then
Mhm.
it's going to end up being, I don't know, hour and a half or so. Then if they end up having the implant kind of reconstruction, which initially I don't have the plastic surgeon put in the final implants. We put in what's called an expander, which is a temporary implant. And
Mhm.
one of the reasons that we do that is the final implants are really heavy. And I don't want that weight on my fresh incisions. It just causes problems. So we don't do that.
Mhm.
So we put in the expander. And then they will go back at some point for a second surgery to exchange the expander for the final implant. But if they go that route, then it's about the same amount of time. So about a 3, at most 4 hour operation, somewhere in that range. Now,
Mhm.
if it's the belly fat that we move up, and basically it's a tummy tuck, but instead of discarding the tissue, they move it up and they reattach these tiny little blood vessels on each side to the blood vessels kind of behind the breastbone. And then, so it's your own fat. You get a tummy tuck. Like patients like that a lot. Have a tummy tuck, and
Freebie.
that's right, a freebie.
Mhm.
And that's a much longer surgery. That's somewhere between a 6 to 8 to maybe even 9 or 10 hour operation. But
Mhm.
we do it every week, and we have a great team that does it. Patients do great from it, so it's a very well tolerated surgical reconstruction. Then stay in the hospital if they have the tissue expander implant route, typically overnight. And with the belly fat, the DF, typically about 2 or 3 days, and they would go home.
I mean, most, because mastectomy got such a bad name for good, for the obvious reasons, because of the Halsted
Mm.
procedure was so brutal for so many people. But what you're describing is more like a simple mastectomy, right?
It would
Just a
be. It would be. So, well, we
more
typically,
typically.
right. I mean, as far as we're saving all the muscle, there's no reason to take muscle on patients. So we're not
Right.
removing muscle. We're saving all the skin. So, I'm
How about the lymph nodes?
usually we'll take out at least one lymph node with a mastectomy. Typically, we would. And so
Like a sentinel node
a
or
sentinel
something?
node, exactly. Typically
Hmm.
take out a
Hmm.
sentinel node with these patients.
Yeah. And so there's a big advantage to doing, people may not realize this, that there is an advantage to doing the mastectomy over doing the lumpectomy, because the lumpectomy requires radiation afterwards, but the mastectomy doesn't, right?
Right.
Usually,
Right.
assuming it's not a high risk type of cancer.
Right. I
But
mean,
there's no, I mean, the radiation is, when they say lumpectomy, people don't realize that really what they're saying is lumpectomy plus radiation. There's no category, except for very elderly or frail people, I would say, that you could just do a lumpectomy and just leave it there. So I think a lot of women are shocked when they are told, now you have to have radiation, and plus you might need endocrine therapy, you might need chemo as well, but the radiation's always part of the package, right?
it is. So the hormonal therapy and or chemotherapy is really the same no matter what surgery they choose. So a lot of patients have the misperception that if they have a mastectomy, they get to skip the chemotherapy, and that's not
Hmm.
true
No.
because we actually recommend the systemic treatment, the chemotherapy or the hormonal therapy, by it's really for the body, not for the breast. And that's really dictated on the lymph nodes and the pathology reports. And it doesn't matter which surgery you have. But you're absolutely correct as far as the radiation. We don't usually give radiation with mastectomy. Sometimes we do, but that's the minority, vast minority. So you're right. You get to skip the radiation if you choose to have a mastectomy. And the other is peace of mind. A lot of patients say to me, I just don't
Hmm.
want to worry every day for the rest of my life. Is today the day that I'm going to
Yeah.
get my new breast cancer in the same breast or the other breast? And so that's not an unreasonable reason. And I think
No.
that's perfectly fine and
Sure.
perfectly
Well,
legitimate.
a lot of breast cancer. This has been known since the 70s, that a lot of breast cancers are multifocal. It's sort of field cancerization. There are dots of cancer. About 40 to some estimates are as high as 80% of breast cancers were there. If you look closely, in other words, if you send that to a very detailed pathology of breast removed during mastectomies, you'll very often find, right, other micro tumors in the breast. So it's not at all unreasonable to feel like if we've got one cancer in the breast, there's always the potential for another cancer to occur in that breast. Am I right about that?
That is true, and that's the other reason that any patient of mine who's considering a lumpectomy, I always have an MRI before I'll perform a lumpectomy. And the reason
Mm-hmm.
is we do find things. We find
Yeah.
other cancers in the breast. We find cancers in the opposite breast.
Yeah.
So it really can. And if we're going to have a cancer elsewhere in the breast that you don't see on mammogram and ultrasound, I'd rather know about it now and
Yeah.
say, you know, you're better off with a mastectomy because it's two separate areas than have her do a lumpectomy, then have the radiation, and then a year from now have that cancer pop up, and then it limits what we can do as far as the cosmetic result of the reconstruction. It's just better to know up front.
And cosmetically, I mean, ironically, what you're describing, your nipple and skin sparing mastectomy, seems to have a better cosmetic outcome than if you had a lumpectomy and didn't have reconstruction on it, then you've still got some disfigurement from because sometimes it's not a lumpectomy could be a quadrantectomy. You can wind up losing a quarter of the breast or a partial, you know, mastectomy. So it seems like this would be a very good alternative to, unless you're going to have the lumpectomy and then have reconstruction, and then it's just a wash, right? I mean, your procedures sounds like it would be just as good, if not better.
Well, it depends. And I mean, I do a lot of lumpectomies. I don't mean to sound like I do only
Yeah,
mastectomies. I do a lot of
yeah,
lumpectomies, and it really depends. I mean, if it's a very small little tumor,
yeah.
then their patient may not even can tell she had something done a year later. So it can be a beautiful result from a lumpectomy, even with radiation. So I don't. It, you have to just look at the patient and the size of the tumor, and there's not an absolute size that I say this patient has to have a mastectomy. It's more the ratio and proportion of the tumor, or we need to resect, to the breast.
Hmm.
So what that means is in a woman with a very, very small breast, I would be more concerned about doing a more generous lumpectomy than I would in someone who has a very ample breast. I could take out a lot of tissue, I could pull it back together, it would look great. So it really depends
Hmm.
upon what I think is going to be the end result. And I'll be very honest with patients. I'll tell them, I can do a lumpectomy on you, but you're not going to want me to because it's not going to look good afterwards. You look
Hmm.
better with a mastectomy and a good reconstruction. And a lot of patients make that decision. Some patients say, you know, I just want to save my breast. I don't care as much about how it looks. That's a rare patient, but some of them do feel that way. And
Hmm.
I try to help guide the patient to the right decision for her.
At Cornell Weill, is there a long waiting time to get in for treatment?
No, no, we try to see our patients as quickly as possible. So, I mean, generally, a patient who calls with cancer for surgery is usually seen within definitely 48, sometimes 24 hours.
Oh,
And
that's great.
one thing we can do now that's really one of the only good things that came out of COVID is that we can also do virtual visits with our patients and have a conversation with them.
Telehealth.
Telehealth. We can do a telehealth visit. We can do that the same day sometimes and just have a conversation and
Hmm.
then get the ball rolling as far as any additional tests that need to be done and then get those tests and then see them in the office for the confirmatory examination a few days later.
If they're candidates for cryoablation, approximately how much time would elapse between the time that they've contacted your department and the time that they could get the procedure?
Well, right now we're only doing on the trial. So I
Yeah.
think there's going to be a new trial pretty soon. So that will actually be another opportunity for women to be able to come in and get treatment with
Uh-huh.
cryoablation.
Great. Well, thank you so much. This is really great. I'm so I'm so amazed at what you've done and sort of energized by it. I want to get out there and shout this from the rooftops because this is, you know, we have so many different alternative ideas and different people who have sometimes wonderful concepts. You've had a couple of wonderful concepts and you've managed to put them across. And that's the rare thing. The rare thing is to actually not just have a good idea, but to achieve it and see it in practice. And I think this is going to change practice tremendously all over the world, but we've got to get the word out about it. So thank you again, Dr. Simmons. It's been really great. And for the Moss Reports, this is Ralph Moss.
Thank you for listening to The Moss Report. Visit our website at themossreport.com and subscribe to hear more discussion of cancer treatment options, alternative research, and more. For more information about Dr. Moss and his work, including scheduling phone consultations, go to mossreports.com.